Last day we discussed a normal ECG and regarding determination of heart rate and initial few parameters of the ECG. Now we are discussing an abnormal ECG. Here you can see the rhythm strip. This is the rhythm strip in the ECG. It is a normal sinus rhythm because every QRS is preceded by a P wave and they are all regular. So this is normal sinus rhythm. Now we'll just have a check of the heart rate. We'll see the RR interval here. The RR interval is 4 large squares or 20 millimeter. So we'll divide 1500 by 20 and you'll get the heart rate as 75 per minute. So this is a normal sinus rhythm occurring at 75 per minute. The leads are all well seen here. These are leads, limb leads 1, 2, 3. These are augmented limb leads AVR, AVL, AVF. These together are the limb leads. Then we have chest leads. You can see this group is V1 to V3. Then V4 to V6. Here you can see the standardization 10 millimeter per millivolt and speed of the paper is also there 25 millimeter per second. Sometimes you may need to take it at a faster speed like 50 or lower speed like 12.5. Then during electrophysiology studies, even up to 200 millimeter per second may be used. In such situation, all the waves will be seen as very wide. So we have to know the speed. Then here digital filters have been switched on that we will discuss later. It's a more advanced topic. Now the striking abnormality in this ECG are the tall R waves. The QRS complexes are very tall. That is because of left ventricular hypertrophy. Here the R wave amplitude is about 32 millimeter in V6 and there is a prominent S wave here in V1. This will be around 18 plus 32 equal to 50. V1 S wave plus R wave in V6 together is around 50. If it is more than 35 millimeter, it is left ventricular hypertrophy by the Sokolov-Lyon criteria. That is satisfied here. A tall R wave itself is diagnostic. If it is 27 millimeter or more, here it is 32. That's also a feature of left ventricular hypertrophy. There are other features also which we will discuss later on. Another striking feature seen here is that the ST segment is depressed. Normally the ST segment should be here. It is depressed. It is a down-sloping ST depression with convexity upwards. This is the classical strain pattern type of ST depression. And the T wave is inverted. The T inversion is asymmetric. This is a more sharper rise, while this is a slightly curved descent. This asymmetric T inversion, ST depression, downsloping, is part of the strain pattern. Along with this tall R waves, you will call this as left ventricular hypertrophy with strain pattern. That is usually seen in overload of the left ventricle, systolic overload or pressure overload, that can occur in severe aortic stenosis, severe systemic hypertension of long duration, an obstruction in the aorta known as coarctation of aorta. These can cause severe left ventricular hypertrophy with strain pattern. Another genetically determined condition known as hypertrophic obstructive cardiomyopathy, in which without any systemic hypertension or aortic valvular stenosis, there is thickening of the left ventricular muscle. There will be obstruction below the aortic valve, that is known as subaortic stenosis, or that is due to obstruction in the region below the aortic valve. Left ventricular outflow tract obstruction in hypertrophic obstructive cardiomyopathy. Even in non-obstructive varieties of hypertrophic cardiomyopathy, ECG will show left ventricular hypertrophy pattern, but it is more marked in left ventricular outflow tract obstruction. So this is systolic overload pattern. What you have seen is systolic overload pattern, where ST depression is associated with T inversion. There is also a diastolic overload pattern in which the stall R wave will be there and there may be a small initial Q wave, narrow Q wave will be there in diastolic overload. Typical condition in which diastolic overload is seen is severe aortic regurgitation. It can also occur in large patent ductus arteriosus. So a small Q may be seen there. Here you can see that there is no initial Q wave in left ventricular hypertrophy with strain pattern or systolic overload. And in diastolic overload, instead of this ST depression, there may be a slightly concave upwards ST elevation, and T is a bit tall and upright. So minimal ST elevation may be there, tall upright T waves, and initial narrow Q waves. Q waves are less than 40 millisecond. When I draw it, it is not that narrow. That's because it's difficult to draw with the mouse. So I'll draw it once again. A very narrow Q wave and some ST elevation, concave upwards with tall T wave. That is a feature of left ventricular diastolic overload seen in severe aortic regurgitation and large left-right shunts like patent ductus arteriosus.